Truthfulness is impossible. So not telling the whole truth couldn't possibly be a violation because it's impossible not to violate it then. We would always necessarily be violating our patient if truthfulness was an actual requisite of medicine, because patients don't understand everything that doctors do, and doctors certainly don't know everything about the world. It's impossible at this point, especially in the 80s, right? So that's another reason why it's therapeutic. We already are making these kinds of decisions all the time, these people are saying. All the time I'm deciding whether or not someone needs to know something. Bach mentions a bunch of studies done on patients and what patients want. One of the things they don't want is bad news. Still true today. Time and time and time again, you do surveys on patients. They don't want to hear bad news. People don't want to hear that they're dying today. And so people who are in this side of the debate are saying, not only do I think it can cause them pain and confusion, they don't even want it. So if they don't want it, why would I tell them? So that's what we got going on here. Let's turn to a violation. We said that patients don't want bad news, but these same studies that Bach is saying these people cite that show patients don't want bad news, is patients would rather hear bad news than not. Both of these things are true. Patients don't want bad news. They don't want to hear bad news. That's not what they walk into the doctor's office or the hospital wanting to hear. That established, if they have no choice, if the bad news is something that they either have to or not be told, they would rather hear bad news than be deceived. This camp, people who believe that deception can be therapeutic, they're right that this will cause harm or that patients don't want this. That's true. That being said, patients would rather hear that bad news than not hear it, if the bad news has to happen. The next thing Bach says avoids unnecessary pain and confusion. Well, she says denial is not universal. These concerns that these people in deception is therapeutic are bringing forward, that it will cause undue pain or confusion, those concerns, she says, are based in a denial of the reality. And clearly not everyone is in denial about facts and reality. There are plenty of cases, thousands and thousands and thousands and thousands of cases of people knowing full well that they're going to die soon. In fact, Bach says, a lot of people go in to the oncologist, the cancer doctor, and they know before they even meet that doctor, their chances of hearing bad news that they're going to die is already present. So to say that they're going to be in denial will cause pain and confusion is to not recognize the diversity of responses humans can have to this kind of information, right? And then she says, you say here we want to avoid unnecessary pain and confusion, and I told you that that's based in these ideas already of doing good and doing no harm. Bach says, look at this first square basically. She's saying, what about autonomy? Deception deprives autonomy. You shouldn't do harm to your patients. You should do things that you think will cause good to your patients. This is all true. But just as you should do that, you should recognize their autonomy. At this point, people were figuring out patients had autonomy. This was the height of a change in the world of medicine away from paternalism towards an autonomy model. It was big news at the time. My decision about how I want to die, my decision about if I want you to do CPR on me, if I lose my consciousness and my heart stops. That choice, that decision, is based on me making an educated choice about what I want to happen on me. That education can't happen if I've been deceived. Autonomy, she thinks, only happens when people make their own decisions based on adequate and accurate information. If they've been deceived, you've deprived them of their autonomy. She's defining autonomy to mean you have to know certain things in order to make an autonomous decision, which is controversial, we should say. Not all people think you need to have accurate knowledge about yourself or your condition in order to make autonomous decisions. But Bach's saying you do. Why? Because it impacts their ability to make personal decisions about end of life. For example, I might want certain things to happen to my money and my estate after I die. But if I don't understand that I am dying and that risk is coming urgently and emergently, then I might elect not to fill out my living will or my will, period. And suddenly the things I wanted to happen has been deprived from me because the person on this side thought deception was therapeutic. So it's a violation of my autonomy. The other thing it's a violation of, according to Bach, and this is the final point on this side, is it's a violation of trust. This, she thinks, is a big deal. Why is it a big deal? Part of it is it'll cause harm to them. You know, I think she quickly is aware of these principles that I've shown you. So she talks about this will cause harm, by the way. She says, look, they might have anxiety, they might have depression because they think their doctor doesn't know why they're dying, and because the doctor is deceiving them because they want them to pursue different things or control the situation, so to say, because that's the behavior the doctor is doing, they might end up falling into some deeper anxiety or depression because they don't know what's happening to them. But if they come to find out you knew what was happening to them, you will not trust them. If I think you might be telling me what you think is best for me, that might be therapeutic for me, even if I'm not dying, I might not trust you or the institution to give me proper care. And that will inevitably cause more anxiety, more depression. But it's literally like, look, if you can't trust your doctor, your nurse, whoever you come in to at least tell it to you straight, you're probably not going to go. The doctors and nurses can't even care for the patients. No one is going to come in and get care if they don't trust you to provide them care. And Bach was sort of predicting in the 80s, technology is going to make it more and more isolating to be a patient in the hospital. Bach was saying the more technology we get, the harder it's going to be for patients to trust their doctors. They should at least believe they have the ability to know what the doctors are telling them is true, and that they have the ability to make their own autonomous medical decisions. Think about how hospitals work now. Some hospitals, not the hospital I work at, but some hospitals are having doctors come in on screens in the hospital room. The doctor doesn't even walk in the room, on a screen, and talking to the patient that way. There are surgeries now being done by robots. Technology is progressing, and we're seeing less and less and less and less of the human element, so to say, of medicine. But Bach says the only way that medicine can hold on as technology continues to progress is that we have to believe physicians will really tell us the truth, that they would give us the right to make autonomous, educated decisions about our own care. If you try to tell me what you think I need, you've deprived me of my right to tell myself what I need. She mentions a few exceptions. You could deceive a patient if that is what they wanted. So it's still autonomous. An example I know is, I know in some sects of Orthodox Judaism, I don't know exactly how or why or if there's disagreement, but I know some Orthodox Jewish families do not want to tell their dying that they are dying, because the idea is supposed to be those who will continue to live should settle the affairs of their estate. This is like something in the religious tradition of Orthodox Judaism that some of these Jews believe. Examples like that, Bach says, they have the right to request their doctor not tell their mom that they're dying if their mom has agreed ahead of time that that is what they would actually want the doctor to do in such a case. And this does happen. You know, I have personally seen this. And this is a thing that people who are in this camp do actually believe, which is like, oh yeah, no, we should, if they ahead of time asked us not to tell them, we shouldn't violate that autonomous request and we should just not tell them as they requested. She also says sometimes there might be reason to believe we could justify concealing it temporarily. An example of this would be like you see something on a scan and you think that that might be a cancer tumor, but you don't know. You could justify not telling them why you want to do another scan because you actually don't know for sure that that's what that was, right? Those are reasons you could hold back the telling the truth. But Bach says, if that's what you're going to do, the burden of proof, that is to say, like, the person who has to prove something is the person who says, I'm going to hold this information. So, like, you would have to demonstrate why it is you withheld information. And in that case I just mentioned, it would be something like, I'm actually not sure that I saw something. I might be mistaken. That's lies to the sick and dying. The other thing that we read was called Truth in the Physician. Meyer tells you exactly his perspective in the title. This is written from and for the perspective of physicians. That's not to say nurses don't also deal with some of this stuff, but it's worth acknowledging. Meyer is talking about who he is, which is a doctor, a physician. He's saying, here's what I am. I am a physician. This is my experience, and here are my concerns. It's worth just sitting outside the gate. He's not coming into this as a non-biased thinker. He is a physician who will have to lie or not lie to patients. Up until very recently, when he's writing this, I want to say it's the 60s. Okay, so this is the 70s. This is the 70s, actually. He's in the 1970s, and he's saying, up until now, there has been no historic conversation about whether or not I'm allowed to lie. Historically, the relationship between patient and physician went from the physician towards the patient. That was the relationship. Now he's saying in the 1970s, there's this newfangled idea that it works both ways. That the goals, the objective, and the values of the patient impact the care and the resources the physician provides the patient. So he's saying all that history I shared at the beginning of this lecture, right? He's mentioning it. Then he's saying no one ever taught us how to communicate with our patients in this way. Historically, it worked like this. The physician has something to offer the patient. Now, as history is changing, the patient has something to offer the physician, which is the values, the goals, the meaning that the patient has for their care, that the physician now has to incorporate, right? He's saying no one ever taught doctors this side of the equation. What do we teach doctors in med school? We teach them the body systems, issues with the body systems, diseases, things they can use for those diseases, pharmacology. Those are the things we teach them. And then we teach them what the law says, right? So we teach them, you can't do this because it's against the law. My understanding is this is actually still, in many ways, how medical schools operate. Most of med school has been teaching doctors about medicine. There is like a class that they take that is about law. No one's ever telling them how they communicate with patients. And then, Meyer says, this can be super emotional. In the case of cancer care, cancer was a super emotionally dense thing in the culture. It was just something that there was a lot of emotion about it. People had cancer personality. Cancer was this thing that happened when you repressed your emotions. If you're an emotional person and you held all that in, it would create a cancer. That was the pseudoscientific idea of cancer in the 20th century. And so, although this physician might actually know legitimately that's not what cancer is or how cancer is formed, no one taught him how to communicate because that's just not how, when we created medicine, no one was thinking about this relationship, right? Let alone were they thinking about how you would even communicate in that relationship, let alone would they give any sort of practical guidance on how to communicate with that patient when that patient is imbued with super emotional and cultural things like pseudoscientific theories on the origins of cancer. Telling a patient they're going to die can be emotional. You're telling another human being that their life is going to end. That, I can only imagine, is terrifying. So there's a lot going on there. And then he gives us a few reasons why this can be exceedingly difficult. He calls these the psychological barriers of the physician. First, he uses a big word, counterphobic motivations. Counterphobic. What does phobic mean? Fear. These are the fears of death and illness that the doctor has themselves. So counter, which means something like against, is referring to this person has to tell their patient that they're dying of cancer, but they themselves are actually afraid of cancer. It also counters, right? It actually is also the case they're afraid of cancer and they're afraid of dying. So the fear that they imbue on the patient is actually also still reflected in their own personal fear of getting told that same news. There is a counter phobia. So they might want to avoid it altogether. They don't want to think about cancer or death because they themselves don't want to ever hear the news that they're getting cancer, and they don't ever want to hear the news that they're dying. So they're motivated against communicating because of their own fears of being told the same thing. That's what counterphobic means. Physicians have a psychological barrier in that they themselves are personally afraid of illness and death. That's one. Two are what he calls rescue fantasies. We teach doctors how to save lives. We teach doctors how to perform surgery, how to give medicine. how to recognize certain things and diagnose the problem and then treat it. That's 95% of what medical school is. So he says psychologically, since you spend almost all of your time actually rescuing people, actually saving your lives, you might delude yourself with the fantasy that you could save them. And if you have all of these other different reasons why you might not want to tell them, I might not want to tell my patient that they're going to die because I'm afraid of dying and I don't know how to communicate with them, and this can be super emotional. And I also was taught that I could save people like this, so maybe I can save them. One of these psychological barriers to communication, Meyer says, is actually this belief that maybe I can save them. So Meyer looks at all of this and he says there's a spectrum of things you can do between always telling the truth and never telling the truth. All possible decisions are somewhere in that spectrum. He says something interesting. These are both moral arguments. People who say you should always tell the truth or you should never tell the truth, or even the example given by Bach, which is deception is always therapeutic or is a lie, those sort of classifications are moral. This is the work of a philosopher. Only a philosopher, he believes, could ever truly think that in every single possible case, you have to tell the truth, is his belief. And only a philosopher could believe you are never obligated to tell the truth. This is interesting. He says, most us normal people, he thinks he's a normal person as a physician, I digress. Most of us normal people live here, somewhere in between the world of the philosophers. Here, he says, individuals make decisions about what has to happen. His point is basically, cause as little harm as possible. This is different than what Bach said. Bach said, as a matter of principle, we always have to tell the truth for patients because doing anything else will always violate them of their right to autonomous decision-making, and telling them anything different will always violate their trust. He's saying that's only something a philosopher could believe. What information can the patient handle? Do you have a patient who is emotionally unstable? He says, assess the patient's readiness and needs. Just as a doctor assesses a pain level and gives an analgesic, which is a pain medicine, gives a pain medicine in response to the assessment of the level of pain. He says a physician should assess the readiness and needs of their patient and give information accordingly. He says modulate the amount and type of information. Meyer says you give them the amount of information, the type of information that they can handle, that they as a patient could reasonably handle, that they are ready to handle and that they need to know in order to make the types of decisions that Bach said that they really should. If he has a patient here who's acting out emotionally, who can't handle the news that they're going to die, and he thinks telling them is going to cause harm to them, Meyer thinks he doesn't have to tell them. He thinks someone is going to freak out and that is going to cause pain, and they are not going to make decisions. They're just going to live the rest of their life wishing that it wasn't so that they were going to die emergently. Then he thinks he doesn't have to tell them. Bach thinks you do, because that's not a decision for you to make. Finally, he says you have to do whatever possible to maintain hope in a realistic framework. Hope is a powerful drug. He gives all kinds of examples where patients have overcome difficult cases. This might not be the glioblastoma. You have no chance practically of surviving. This might be you have a 30-70% chance. But if you knew 3 of 10 people died, you would get freaked out, you get scared, and your body might actually physically respond biochemically, physiologically to that anxiety response. That's something we know that happens. So he says, I need to do what I need to do in order to maintain hope because it has better health outcomes. This is all part of a larger point he's making that minimizing harm is more important than strict truth-telling is what he calls it. That do no harm principle, he thinks the reason that gets taught in medical schools and honesty doesn't is because in reality, only philosophers could come to the conclusion that you always have to tell the truth. Sometimes you can withhold information if it minimizes harm. Bach would have called this deception. She would have said this person is on the deception as therapy team. He's not calling it deception. He's calling it a minimizing of harm. He's causing as little harm as possible. And he's even saying, my default should be to tell the truth. Meyer thinks he should tell the truth when possible. But he does think it is ethically justified to withhold the truth. I think that here's really where the tension is. Are there things that we just have principled obligations to, like telling the truth to our patient? Or instead of thinking like a philosopher, is what Meyer said, should we just do the best we can to minimize harm? But now it's time for you to reckon with this idea.